On behalf of the chairpersons V3, we thank the organizers for giving the opportunity for this session. We have three topics with three speakers. Without wasting time, since we are running short of time, I like to ask the first speaker, Dr. Nandita Arun, who doesn't need any introduction. So she's going to talk about oral GLP-1 regarding the drug with weight control as well as CV reduction, risk reduction. Over to you, doctor.
Good afternoon to all the senior doctors here today. And of course, before I move on to the topic of the day, I'd like to welcome those who are here out of Tamil Nadu to our own state of Tamil Nadu. And very happy to see those mementos, which very beautifully signify our part of the world, part of India. And of course, thank the organizers for having me here today. So I'm going to be talking about, in the next couple of minutes, about 15 minutes or so, the role of GLP-1 therapy in the management of type 2 diabetes. Of course, these are agents that have been around for quite some time now, but specifically the role of oral GLP-1 therapy, when and where to use it and how does it fit in, and how has this actually changed our approach to the incretin therapy. This is my financial disclosure. This session has been supported by Novo Nordisk. And this is the agenda of my talk, but I'm going to move on to the first slide, which is decoding the so-called trinity of the complexity of the metabolic condition, type 2 diabetes, obesity, dyslipidemia, and cardiovascular disease. We know that this so-called unholy trinity that the slide alludes to over here, insulin resistance, obesity, type 2 diabetes, dysglycemia, dyslipidemia, all this is one continuum that ultimately results in the increased risk of cardiovascular disease. And of course, we know that there's a whole lot of data that a lot of numbers that I'm going to put over here, show you here. But we know that you can't really dissect one from the other. Like I said, it is one continuum, so hitting hard, hitting early, screening and detecting risk factors early is probably the key to reducing the cardiovascular burden in our patients. Now, these numbers that you see here are mostly Western data. But again, because we are sitting here in Tamil Nadu, in our part of the world, I wanted to show you some Indian data, South Indian data. This is data that we recently published, which is called the STRIDE study. So we had published we've been serially publishing, my father, Dr. Ramchandran, has been publishing a lot of data on the epidemiological prevalence of type 2 diabetes in southern India. And the last that we had published data was in 2006. So we wanted to go back 10 years later, and why I put this map over here is to sort of show you exactly where the areas and to set the context. We wanted to go back to the same areas 10 years later to assess and see whether there is in fact an increase in trend in not just type 2 diabetes, but what is the risk in cardiovascular risk factors, including obesity, etc. And again, not just in Chennai, which is not just in the urban setting, but also in the rural settings, as you can see in Panruti and Kanchipuram. So this is what I was telling you, the data that we've been publishing over the years, right from 1980s, where you can see it was in a single digit in Chennai, the prevalence of type 2 diabetes, which has then been exponentially increasing. And the publication that I had showed you earlier, the so-called, what we termed as the STRIDE study, from 5%, the prevalence has now increased to 22%. Does this pointer work? I don't know if it's, no, okay. This one? Okay, thank you. So as you can see, from a mere 5% exponential rise to 22% in the urban areas, and from a mere 2% to almost 14% in the rural areas. And this, what I'm showing you here, is data from our own Tamil Nadu, our own Chennai, and in rural settings like Kanchipuram and Panruti. So then we moved on to look at, now we know that there is an increase, but what are the risk factors that are significantly contributing to this increase of type 2 diabetes? We know that we, as an ethnic group, as Indians, do have a higher propensity or a higher risk to develop insulin resistance in type 2 diabetes. But other than a positive family history, of course, which turned out to be a significant risk factor, positive family history and age, one of the most important, significant, independent risk factor that contributed to the increased risk of type 2 diabetes, again, not just in the urban, but also in the rural areas like Kanchipuram and Pandruti was an increased waist circumference. Again, what I want to bring your attention to is that there was also a significant increase in sedentary life habits, a reduction in physical activity in the village setting, not just. So we used to think that people in the villages walk more. We used to think that it is only in our part of only in the western, in the city, in the urban population that there is a rise, and that our physical activity is reducing and only in the urban setting. But this is data to show you that it is not just in the urban setting, but also in the rural areas, there is a significant explosion of type 2 diabetes. And if I move on to the next slide, you'll see that there is a significant rise of also obesity, again, not just in the urban, but also in the rural areas. And it is not just generalized, but also abdominal obesity. And this was an independent risk factor or a risk variable that is contributing to that increased risk of type 2 diabetes. So just like in the previous sessions on SGLT2s where we were discussing obesity, we always think that, oh, obesity is only in the western part. It's not a problem in our part of the world. It is a problem. It is a problem, and that is the problem which is also contributing to that exponential rise in the burden of type 2 diabetes, which in turn is increasing our burden of cardiovascular disease as well. So moving on, as I addressed earlier, type 2 diabetes, obesity, abdominal obesity, visceral adiposity, dyslipidemia, all this is one continuum resulting in an increased cardiovascular risk. And the action that we have to take is, of course, we all know, increase physical activity, lifestyle changes, dietary improvement in dietary habits, evaluation, early screening, detecting risk factors early and intervening at the right time, and a more holistic multifactorial approach which involves controlling not just the blood glucose but also lipid management, blood pressure management, weight management, and last but not the least, I think now it is well accepted and we are now in an era where we've come to realize, and even the guidelines do guide us, that it is not just important to address all these factors, but it is equally important what agents we use in our patients. So it's not just about reducing that blood glucose anymore. It is not just about reducing the blood pressure or not just about reducing these risk factors, but how we do it, what agents we use to accomplish these goals or to achieve these goals is also equally important. And that is what the ADA and the recent guidelines also tell us. So when it comes to this multifactorial approach, the one group of agents, of course we have a whole array. Today we are in an era where we have a whole array of agents. Just about, say about 15 years ago, we had insulins, of course, we had metformin, and then we had the sulfonylureas. We were left with just these juggling between these three agents when we are faced with a patient with type 2 diabetes. We know that failure of these agents, failure of metformin, sulfonylurea, failure of which the next option is mainly insulin. Of course, we do have some agents like the alpha-glucosidase, but weaker agents that we had available. But today, as clinicians, we have a whole range of agents to choose from, including the DPP-4 inhibitors, the GLP-1 analogs, the SGLT2 inhibitors, the combination therapy with all these. And amongst all these groups of agents that we have, the GLP-1 therapy has right from the start been a promising group of agents that provide benefit not just in terms of glycemic benefit, but a lot of extra glycemic benefits that they come with. They reduce blood glucose without the risk of hypoglycemia. They induce weight loss. They reduce cardiovascular risk, they improve renal outcomes. Beyond all this, they also provide improved quality of life, and also I'm going to show you all the data. Of course, I'm alluding to all these points, but this is what I'm going to be addressing in the next couple of slides. So oral semaglutide, of course, this is the molecule, you're looking at the whole landscape of GLP-1 therapy. I think as clinicians, we can all agree that when over the years, the biggest challenge with GLP-1 therapy that we've always faced is the fact that they have been 2 points. One, injectables. Two, the cost. Now, the cost is something that's beyond the scope of discussion over here. I think that's for another day. But the fact that they were injectables was a big sort of challenge, and that barrier has now been broken by oral semaglutide or Rybelsus. And I still remember Novo Nordisk at their launch of Rybelsus, where they named it the game changer. That was their tagline, and I think it's literally been that, because it has broken that barrier and it has made it a lot easier for us to initiate GLP-1 therapy in our patients. Because we all know how the moment you mention an injection, the patient withdraws. So now that barrier has been broken, and the only oral GLP-1 therapy that we have available today globally is semaglutide. Of course, it is very similar to the human GLP-1. I'm not going to go into the details of the molecular structure here, but of course, Novo Nordisk always has that spacer and the zinc which is attached. And here, the technology is that it comes with a SNAC technology, which makes it more conducive to being absorbed in the gastric and the intestinal level. But moving on, due to lack of time, I'm going to move on to some of the clinical data that we have. The group or the landscape of data that we have available with oral semaglutide have been called the pioneer studies. There's a whole, it's been studied in almost every other group. You have Pioneer 1 versus placebo, Pioneer 2 versus SGLT2, 3, 4, 7, 8, and most importantly, Pioneer 6, which is the cardiovascular safety trial with oral semaglutide. Most of these trials I'm going to run through to summarize what the results from these trials is that there's a significant HbA1c reduction across trials of around 1 to 1.5. Significant weight reduction, and what I'd like to bring your attention to is Pioneer 4 versus liraglutide 1.8 versus oral sema 14 mg. You find a more significant drop in body weight, and this is, there's no conflict of interest there because Novo was marketing both the drugs. So oral sema versus lira, you find a more significant weight loss, up to 5 kg weight reduction. The weight reduction is not just overall gross body weight, but also significant reduction in abdominal obesity. And this is very relevant because I showed you data to show how our population, this is an increasing risk factor. Oral semaglutide, there's also data from all these pioneer studies to show us that there is also some reduction in blood pressure, improvement in lipids. Last but not the least, also some data to show that there is a mechanistic, probably one of the hypothetical explanations for the cardiovascular risk reduction. There is an improvement also in CRP levels, and this probably, and in comparison to empagliflozin, which probably results in some cardiovascular risk reduction as well. So to summarize what the results of the Pioneer study shows is that there is improved glycemic control without the risk of hypoglycemia, weight management, blood pressure reduction, lipid reduction, inflammatory markers coming down, and improvement in waist circumference, last but not the least. The last few slides of my talk is going to be on the cardiovascular safety of oral semaglutide. This is the Pioneer 6, which I was alluding to earlier. The Pioneer 6 was a dedicated cardiovascular outcome trial in which it was placebo versus oral semaglutide, and the results of which is what you're going to see, what you're seeing on the right-hand side. With patients with established cardiovascular disease 60 years and above, significant improvement in body weight and HbA1c reduction, high retention rate, and this is a very important point. One of the biggest challenges with GLP-1 therapy that we face, again, beyond the fact that they are injectables, beyond that now we have an oral drug, the biggest challenge was the GI side effects. And this is excellent data, fantastic data that you're looking at, that they had 99.7% retention, to show that patients were actually following through with the drug, and overall adverse events were low. Last but not the least, the results of this particular trial showed that it was a neutral trial. So there was a non-significant 21% reduction in cardiovascular outcome. So versus placebo, it proved its cardiovascular safety, non-inferiority, but did not prove superiority over placebo. However, Novo Nordisk is now having an ongoing trial called the SOUL trial, which is again a dedicated cardiovascular outcome trial. The sort of rationale behind this is that although the Pioneer 6, the data which I showed you in the previous slide, showed non-inferiority and proved its cardiovascular safety of oral semaglutide, there is data from the SUSTAIN 6 trial, which is with injectable semaglutide, that showed superiority in terms of cardiovascular risk reduction. Hence, Novo Nordisk, since both are the same molecule in different formulations, one an oral and one an injectable, they wanted to prove beyond doubt the superiority of oral semaglutide also in terms of cardiovascular risk reduction, and which is why they now have the SOUL trial to prove its cardiovascular, which is dedicated to prove cardiovascular superiority. There are many other trials like the ASCENT Plus, in which there's looking at primary prevention of cardiovascular disease. a heart failure trial, the FLOW, which is in to show renal outcomes, and then the STRIDE in peripheral artery related disease as well. So a lot of ongoing trials with oral semaglutide, which are dedicated to give us more promising results and encouraging outcomes. The last slide, I think this is my final slide to just reiterate why I put actually the slide deck. I included this slide here because I think this is a point as clinicians we really have to keep reiterating, and every visit when patients come back to us, make sure that this point is sort of addressed and we remind patients, because taking the tablet on empty stomach, I'm sure all of us have been who've been using this now know about this, but many times patients forget and they tend to take it either after their coffee or they assume that it's okay to take it later. But taking it on empty stomach and waiting for that 20 minutes is extremely crucial for the absorption of oral sema, failure of which you're not going to get good results. So to summarize, we have an oral GLP-1 formulation available today at our disposal, which has broken the barrier of the injectable GLP-1s that we've had earlier, with proven efficacy in terms of HbA1c reduction, weight reduction, proven cardiovascular safety so far, and reducing cardiovascular endpoints or cardiovascular risk factors in terms of blood pressure reduction, inflammatory markers, and lipid profile as well. Thank you.
Good afternoon. Next 15 minutes, which I am going to tell you, that will be very clinical for you all in your practice. So I am not see you the many graphs and data, with huge appreciation and thanks to the organization. My topic they have given, is it safe to use SGLT2 inhibitors in all diabetic patients? I think 1 year back there was a beautiful debate at the ESD whether we should use SGLT2 inhibitors in all of the diabetics. That was, but it is not written it is type 1 or type 2, so we will have to discuss both. You are well aware today that there are lots of beneficial effects of SGLT2 inhibitors, and I think just GLP-1 RA oral, Dr. Nandita told that it matters how you treat your diabetic patients, because your aim is not only to bring the HbA1c down, but you have to keep kidney, brain, everything, the heart, everything safe. And so in that list, I think that today, metformin, I will say that it is coming down. It is, in my opinion, it is not at the crown position, although guidelines are saying, but rather the SGLT2 inhibitors is at the crown position at present. So with lots of mechanistic things, this is very important. So you will agree that the drug treatment model of diabetes is facing a profound change today. And these drugs, these SGLT2 inhibitors, because of their unique action, do not depend on insulin or insulin islet beta cells in vivo to give their pharmacological effect. So only by understanding and paying attention to the pharmacological mechanisms can we understand these limitations. When you are going to use and when you are not going to use. To date, this group of drugs have shown bright prospects and are expected to become the clinical first-line drugs for type 2 diabetes, and not I, but many other experts today believe that this is going to happen. So this is a very, very important part to understand. There is how this the group of drugs are targeting the favorable aspects, even the lowering the blood glucose, lowering blood pressure, lowering body weight 3 to 4 kg, lowering the HbA1c, increase the high density lipoproteins, decreasing triglyceride, reducing your albumin level, albuminuria, and reducing the uric acid, and increasing hematocrit. So these parts are quite beautiful and fantastic. But where you are stuck up, that is if you are getting UTIs, GTIs, ketoacidosis, fracture risk is there or not, whether there is any risk of malignant tumors, any hypotension risk, hypoglycemic risk, or lower limb amputation. So these things, where it is safe or not, I am going to discuss you. So in patient with diabetes, there is translating an evolving body of evidence to the nuisance of the practice. The first part is whether you should use in the type 1 diabetics or not. I think you are well aware that lots of trials, DIPIC trial, EASE trial, and TANDEM trial, many parts, and when there was a time when the European Medical Agency approved for the type 1 diabetes. But later on, it was removed. So what was the reason? The first question in type 2 diabetes is, will glycemic efficacy be sustained with chronic therapy? Why you are interested in type 1 diabetics with SGLT2 inhibitors? Because even if you are giving with insulin, you are not protecting the cardiorenal mechanism, are not there with this insulin. So only you are not going to protect the kidneys, the heart and other things with this insulin only. So we need some drug for type 1 diabetics. But if you think about the glycemic efficacy, you can see that the maximum decrease in HbA1c was observed after approximately 8 weeks, but the glycemic efficacy definitely went between 8 and 52 weeks. So at present, there is no convincing evidence to demonstrate that chronic or lifelong therapy would provide a favorable benefit-risk profile, because we don't have the data. And we also don't know what is the optimal dose if you are using in type 1 diabetes. But it has been shown in some trials that if you are using 2.5 milligram, fourfold less than lowest approved to your 10 milligram, this did not increase the risk of ketoacidosis. So this has been shown in the trial. So this completely recommend initiating therapy with the lowest approved dose and raise the possibility of splitting tablets of currently marketed HLT inhibitors. This is the scenario. And what is happening in the real world practice? Recently, I heard a lecture at the ESD at the Madrid, I think 15 days back, and it was, the speaker was telling that off-level use of SGLT2 inhibitors in type 1 diabetes is tremendous. It is not low, it is tremendous, off-level. So we don't, because we don't have guidelines, no guidelines is saying you to reduce. So there are lots of problems. So basically it is important, would be especially desirable to identify patients at greatest risk to develop the ketoacidosis, and that you can do by monitoring the beta hydroxybutyrate levels. If your patient have got a ketometer and he is well educated, it can be done, but it is not possible at the ground level, at the reality, so I think the EMA has withdrawn. But off level, I told you, is very, very rampant. But I believe that game in type 1 diabetes is not over today. Things are going on, and because this cardiovascular, renal and metabolic complications, with this in our mind, we are still researching how to use that. Now in the type 2 diabetes, which is the common problem, you are well aware about the kidney disease progression, AKI or CV death or heart failure. What is best drug in your diabetics? I think this is nothing more in reality except this SGLT2 inhibitors. And then you can see that there could be some problems with this drug in the type 2 diabetes. So confusion concerning their place in complex therapeutic paradigms, let us see let us bridge that gap. The one thing in the type 2 diabetes, remember if when you are giving SGLT2 inhibitors in your type 2 diabetes, lots of cases we miss of the euglycemic diabetic ketoacidosis. And just applying a slight mind about the risk factors that this rare but very serious condition, if you think that there is a profound insulin resistance, if you think there is a low beta cell function by low C-peptide levels, there is restricted food intake. Many times we find that patient has gone to some mountains and somewhere did not take the food, and returning back develop this EDK. Or there is some sudden reduction in insulin or increased insulin requirements. Be careful in those cases if your patient is on SGLT2 inhibitors. And this is very, very important part. Apart from this, you can see the risk and benefits. Benefits are huge, I told you. But the basic problems are that the GTI, postural hypotension, slight increase of DKN, concern about lower limb amputation. Let us see what happens. So if your patient is going for any planned surgery, stop 3 to 7 days, because different guidelines, some say 2 days, some say 48 hours. So I say that 3 to 7 days. Then this GTI, this is really a big problem. I will admit that in our part of world, there is lots of cases in women, men coming with problems and female also coming with the vaginitis, vulvovaginitis and many other things. And many are coming with the pyelonephritis, urosepsis. This is happening. But this is how much is the risk. But I will tell you that as far as this Fournier's gangrene is concerned and lower limb amputation is concerned, be in peace that hardly this happens with this. And these all, you can see these newspapers, that diabetes drugs may cause infection that destroy the genitalia. Flesh eating genital infection, these are all bogus things. All bogus, nothing happens like that. You know how this happens? The genital tract, GTI, glycosuria, then blenditis and blenoprothitis. So if in such cases, just pay a bit of time, you give the education to your patient that whether the patient is maintaining a poor hygiene, topical, these are the risk predisposing factors for genital infections if you are using the SGLT2 inhibitors. Or some pregnancy, estrogen pregnancy you are not using. The moist and warm environment is also very important. And we are also researching whether the tight and loose clothes have some role or not. And genital infections in diabetes are often not transmitted sexually and are of mycotic origin. There is some research paper showing that if you are adding gliptins with the SGLT2 inhibitors from the very beginning, not that you are using a metformin, then you are adding a gliptin, SGLT2 inhibitors, and if the patient has developed UTI or GTI, then adding SGLT2 inhibitors, no. If you are using the gliptins from the beginning, this paper is showing that the prevalence will decrease. Clearly shown that incidence of GTI infections favor the use of, you can have some benefit with this there, although we don't know the exact mechanism, how it happens. So my point is that information of the GTI and the signs and symptoms of decay should be communicated on the regular basis, and counseling between individuals about the importance of adding very low carbohydrate or ketogenic diets and ensuring continued hydration. This is very, very important part, and sick day rules must be followed if your patient is taking SGLT inhibitors. We did a very big study, Genius study. It is under evaluation. I think within next 6 to 8 months it will be published. A huge data, 42 centers, pan-India. I as a principal investigator, and we have found that overall incidence is quite high. Not only GTI, all papers in the world, they are showing that UTI is less. But I don't think our paper is showing it is coming more. So let us see what happens with after final analysis, we go for that. So suppose a patient has developed your GTI or UTI, when you are going to restart. The South Asian Federation of Endocrine Society say that perennial hygiene is okay, but after 3 months of GTI-free status, patients with type 2 diabetes can be prescribed with SGLT2 inhibitors along with prophylactic antifungal coverage. So this should be remembered. And should be avoided in case of previous history of upper UTI, complicated GTI. If there is recurrent GTI or UTI or resistant GTI, don't use at all. And key factors. So let us see some questions and answers, which is in your mind. So is there a greater risk of decay? This is reported rates to be between 0.1 to 0.6%. Only avoid if lead or pancreatitis associated diabetes, and just stop use 3 to 7 days before this surgery. I told you about the surgery. Can it be prescribed for older people? I think there was a lecture just 2 times before that. I think the SOLD study found that it is effective and well tolerated in people when your age is more than 70. I'm really happy, sir, you told that the geriatric population should have more than 85 or 80. 80. So this is really encouraging for all of us. Yeah, thank you very much. So this is just in Diabetologia. This paper came out, and they have shown that SGLT2 inhibitors in older adults and are very effective and do not increase the risk of dehydration, falls or urinary problems for older adults with type 2 diabetes. And in my clinical practice, I find the same thing. So don't give so much of problem in your mind, oh, it is 70, 75, should I use SGLT2 inhibitor or not? Nothing happens, just I told you the acumen how to use that. Does renal function needs rechecking soon after initiated because the EGFR drops? They do not count electrolyte imbalance the way it has been told to you. Can it be used with the loop diuretics? These studies included no issue associated with the concomitant if you are using with the loop diuretics. That is sufficient to say you. Can be used in women who are planning pregnancy? No, don't use it, not licensed. And can it be used in people with type 2 diabetes who are under age of 40 years? you can, you must, I think, because your risk factor is too high. And can I prescribe HLT inhibitor for a person with active foot disease? I think this is a blunder that we told you initially that after canvas trial there are lots of lower limb amputations. In real world history, then in lots of meta-analysis is never found again. So this is not a scenario where there is lots of amputation happening with this drug. And I told you there is not a great risk with the Fournier's gangrene. Even in the kidney transplant patient, today people are using it. There is a protocol, I have not time but to tell you, but there is clinical, pharmacological and monitoring. They are using it even after transplant, kidney transplant, and found very useful. There are lots of protocol for that. So my last take-home points are that today, for heart failure, for nephropathy, for CV disease, you have nothing in your hand because GLP-1R is out of reach to the most of our population. And even this oral semaglutide, I have to stop in most of my patients. They are not tolerating it, so my problem is that. But this drug is really beautiful, and I will tell you that there are so many practical points I told you. You want to consider, do not prescribe if there is acute illness with risk of dehydration, current or previous diabetic ketoacidosis. If there is found a C-peptide is low, there is rapid progression to insulin, don't use. Suspect LADA, whenever you suspect LADA, don't use it. Chronic pancreatitis or type 3 diabetic, don't use it. And suspected pancreatic cancer, never use it. Pregnancy, suspected pregnancy, never use. And plant surgery, I told you what to do. Type 1 diabetes, at present, don't use. And unclear diagnosis of diabetes. Many times you are getting patients coming with KPD, ketosis-prone diabetes. A patient of 45 years coming with diabetic ketoacidosis. And later insulin was not required after 6 months. These are all ketosis-prone diabetes. So in those cases, be very careful. I think I have given the message which I want. So thank you very much. There is nothing like Indian phenotype is there. So I told you everything. Thank you very much for patience hearing. Thank you.
Thank you, sir, for the elegant and excellent presentation in a short time and highlighting all the important points. Thank you, sir.
Thank you.
I invite Dr. Anil Kumar Virmani for presenting fixed dose on triple drug combination on diabetes.
Good afternoon to all of you, honorable chairpersons and dear friends. My topic is where to use fixed drug combinations, especially the triple drug combo in diabetes. No disclosures. If you look at the prevalence of diabetes in India, it is more than 10% in majority of the states. But what is more disturbing is the prevalence of pre-diabetes, which is more than 15%. We all know that we started with the knowledge of triumvirate of the causes of hyperglycemia. It went on to the classical ominous octet of Defonso, and then today we have gone to the dirty dozen, treacherous 13, filthy 15, including even pollution as one of the factors causing diabetes. So our knowledge expanded very nicely as far as the pathophysiology is concerned. If you look at the therapies and primary mechanisms of glucose control in type 2 diabetes, we have got an excellent armamentarium of drugs available to us, and there is no reason why we should not be able to control our patients with diabetes. However, it is indeed very unfortunate that majority of the patients in the Asia Pacific region do not achieve the desired A1C goals of less than 7%. In fact, the India Dedicom study showed that more than 60% of the patients in India are not controlled to the target levels. And the achieved study baseline data published in JAPI way back in 2013 said that the average A1C to Indians is around 9.2, which is disaster as far as the knowledge that we have, the type of drugs that we have, and the advanced diabetologists and doctors that we have. So why are we failing to bring people with type 2 diabetes under adequate glycemic control? The answer or possible explanations are that the number one, clinical inertia. We intervene too late and we intensify too slowly. The other is non-compliance to anti-diabetic drugs in India. As Dr. NP Singh just said, these patients did not take Ribelsus for majority of patients just don't take. You ask a patient who comes to you 6 months after treatment and don't ask him what drugs he's taking. Ask him which drugs he is not taking and you will know that more than 60% drugs that you have prescribed he is not taking. And why he is not taking? Cost, multiple dosing, too many drugs, polypharmacy. And that is the biggest problem that we face, but unfortunately we never try to inquire from the patient whether he is taking those drugs or not. He just writes a prescription and forget it. So early combination treatment strategies represent the beginning of a new era of early detection, diagnosis, intervention for patients with type 2 diabetes with the potential of preventing the progressive deterioration of glucose control and increasing need for additional treatments. The question comes, why to choose triple fixed dose combinations? Obviously the answers are very clear after what I said. Avoid clinical inertia, improve adherence and avoid polypharmacy, simplify treatment approach, improve persistence with medication, and if you can achieve an early glycemic control, you get what is known as a legacy effect. So, and there was a wonderful study which showed that in the first year of type 2 diabetes after diagnosis, if you get an A1C of less than 6.5%, the complications rate are minimal. So this is why we should be choosing the FDC. The next question comes, which is the best combination? He said metformin is gone. I said no. Metformin, we have 6 decades of experience. It is still one of the best drugs. We have DPP-4 with an excellent safety profile, low risk of hypoglycemia. They may lack the cardiorenal benefits of SGLT2, but they are still excellent drugs as far as you want to give a drug to an elderly patient or if you want to give it blindly to any patient, you can be sure there will be no hypoglycemia. And of course, the immense cardiorenal benefits of SGLT2 inhibitor. Now, which one of these two, I'll come to it a bit later. Now, if you go to back to the metformin, if you look, metformin, the history, 57 it was used to treat, 98 the UK pediatric came, 2005 metformin adopted as a first line in diabetes and it is still being doing as first line, though its throne has been threatened by SGLT2 inhibitors. And in 2011, it was put on the WHO list of essential medicines, and in 2022, also indicated in pregnancy. Now, it acts on the intestine, liver, muscle, adipose tissue. In the intestine, there is increase in the anaerobic glycolysis, lactate production, increased splanchnic glucose turnover. Liver, there is decrease in gluconeogenesis and glycogenolysis, leading to decrease in the hepatic glucose output. In the muscle, there is increased glucose uptake, glycogenesis, and increased glucooxidation. Ultimately, there is increase in the peripheral glucose utilization, and the adipose tissue, there is increased glucose uptake and fatty acid oxidation, decreased lipogenesis, and ultimately increase in the energy dissipation, ultimately reducing hyperglycemia. This is a mechanism of action. So the multiple mechanisms of action of metformin are there. Cardiovascular benefits, yes. Heart, it leads to alters the substrate utilization, mitochondrial energetics, increases post-ischemic perfusion, there is an increase in nitric oxide synthase, capillary evolution, and decrease in the glycoxidation and addition molecules. Hemostasis, there is a decrease in the platelet aggregation factors 7 and 13, 1 billion factor, PI increases phenylalysis. In the immune cells, decreases the nuclear factor kappa beta and various pro-inflammatory cytokines. Ultimately, what we are getting is it decreases atherosclerosis and decreases thrombosis. That was about metformin. That is why I say metformin still remains one of the components, major components of treatment regime. Coming to DPP-4, we all know in patients with type 2 diabetes, there is a diminution of the incretin response, decreased insulin, increased glucagon, and hyperglycemia. It is by giving a DPP-4 inhibitor, we increase the activity of the incretins, improve islet function, increase insulin, decrease glucagon and thus improving the glycemic control. Now, DPP-4 causes GIP-mediated augmentation of glucagon secretion, we must remember, in the setting of low glucose, and that is how it prevents patients going into hypoglycemia. Now, there are novel mechanisms of action. We know the classical action is that it augments circulating concentrations of intact, biologically active, endogenously secreted GLP-1 levels in the physiological range, and this is non-linear and not directly proportional, but the half-life is still 1 to 5 minutes only. So there must be something else that is happening and that we are born to know. And it has been shown that even GIP from the alpha cells is also acted upon. Then there are novel partially dependent overall endogen, but there are other factors like portal neural sensing, portal GLP-1 gradient, GIP, his LRD dipeptide, alpha cell mediated response, and these are substrates yet unidentified where the DPP-4 inhibitors are acting, and there are other substrates like pituitary adenine cyclase activating peptide, gastrin-releasing peptide, and oxyntomodulin, which is also acting as substrate, where we are still learning more and more about DPP-4 inhibitors. A very meta-analysis by Fagny has shown that the 33% enhanced DPP activities in patients with type 2 diabetes, and they are very good drugs in patients with type 2 diabetes. What about Asians? We are different from the Westerns, and we all know about the Asian phenotype, and that is the young type 2 develops diabetes develops much shorter time, younger age group, almost a decade earlier, people with lower BMI and more aggressive with higher rate of complications. Even among Asians, there's a difference between the East Asians and South Asians. Maybe if you go to Calcutta or maybe go to Chennai, East Asians in Calcutta have predominantly insulin secretory defect when compared to the white counterparts. While people in Chennai are going to have higher insulin resistance and typically characterized by relatively lower BMI but higher amounts of visceral fat. So that difference is there. And moreover, in the South Asians, a low adipocane level has been shown, and we know that insulin, the DPP-4 are going to increase the adipocane. So there are the other advantages of DPP-4 inhibitors. So this is the revolving landscape: older patients, frail patients, patients with low values of insulin markers, patients with LADA, where you cannot give SGLT2 inhibitors, patients with high risk of hypoglycemia, and at those who are at high CV renal risk, and along with SGLT2 inhibitors. So we all know the actions are metformin, more on the fasting as compared to the postprandial. DPP-4 is more on the postprandial, plus it also increases insulin secretion. So DPP-4 inhibitors basically complement the action of metformin. There are various DPP-4 inhibitors in the market. The question comes which one to choose. Now, if you look at the trials, sitagliptin is the only one that went the TCOS trial, so no specific concern, warning in patients with a history of cardiovascular disease, so it remains the drug of choice. Vildagliptin, no CVOT, there are problems with hepatic impairment and allergic skin reactions. Saxagliptin has shown increase in the hospitalization. The only other drug is linagliptin, which was found to be safe in the Carmelina and Carolina trials. Gemagliptin, again no CVOT. Teneligliptin, again the same problem, and concerns of QTc prolongation. So we have two drugs, sitagliptin and linagliptin. We have to see which is available to us and which is cheaper. Now, sitagliptin, we have a lot of data. It has shown an increase of insulin secretion by 22%, glucagon decreased by 12%, and the glucose excursion by 26%. It also has shown improved markers of beta cell function when you consider the pro-insulin ratio and HOMA beta. And moreover, it reduces glycemic variability. Coming to the gliflozins, we have three: CANA, DAPA, and EMPA. The actions of SGLT2 inhibitors are well known. I don't want to go into details because of paucity of time, but it has got wonderful effects. Major adverse CV effects are lowered all-cause death, cardiovascular death. It improves heart failure of every type, including acute failure. We know it reduces glucose, body weight, BP, lipids, etc. And also the excellent effects on CKD, where it lowers eGFR decline, albuminuria, uric acid levels, renal mortality, and increases hematocrit. Now, as you, this is the wonderful slide which shows the action, the wonderful actions of SGLT2 inhibitors in the wide spectrum of diabetes, heart failure, and chronic kidney disease. And look at this wonder, and this is the 13 large outcome trials. So, SGLT2 combining with DPP4, we know their own actions, but they have indirect actions on the pancreas, indirect effects. The SGLT2 increased beta cell sensitivity and increased glucagon, whereas DPP4 increased insulin secretion, decreased glucagon, so they have a very complementary effects. And thus they can decrease hyperglycemia, plus you can get the pleiotropic effects. And the DAPA gliflozin is the one that I've chosen here because it has gone on a wonderful program, the DAPA care program, and we have the combination of metformin, DAPA, and this thing available. Now this is a wonderful trial which was triple action study. It has done with triple combo therapy, but here they use metformin, DAPA, and saxagliptin, and they instead, and then the other side they use sulfonylurea along with metformin. Now they wanted to see the reduction in A1C and the avoidance of effects like weight gain, hypoglycemia, and discontinuation. And in the combination therapy, the primary outcome was achieved in 39% as compared to 17.1% in the step-up therapy. And the incidence of hypoglycemia, weight gain, or discontinuation drugs was far less, 16% as compared to 62%, and there were fewer adverse events. So what is the impact? We know that one single drug cannot reduce A1C by more than 0.8 to 1%, so we need a combination of drugs, and this is the combination that can help improve not only glycemic control, but reach the targets. So basically, if you look at this combination of SITA, DAPA, and metformin, efficacy-wise, significant and durable reduction, cardiohepatic renal production, beta cell preservation, safety, non-overlapping toxicities, no increased risk of cardiovascular event, weight gain, or hypoglycemia, no drug-drug interaction, oral, metformin still remains the first line, and cost effective. So the key messages I want to give you is that type 2 diabetes is a complex progressive disease that typically requires substantial lifestyle changes and multiple medications. You cannot control type 2 diabetes with only SGLT2 inhibitors, remember. Lower blood glucose, reduce CV risk, address comorbidities. Besides the cardiorenal benefits, we also need to reduce blood glucose. Let us go back to the basics first. There is no sense in leaving the captain of the army and killing the others. You have to kill the captain also. Despite an extensive range of available and effective treatments, majority of our patients still do not achieve less than 7% A1C. Clinical inertia and adherence to prescribed therapies are the two very important factors that are often overlooked. The early combination therapy, ideally with metformin, SITA, and DAPA, avoids clinical inertia, reduces pill burden, improves adherence, well tolerated, cost effective, and early glycemic control, giving us the legacy effect and ultimately decrease of complications, and that is what we want. Thank you for the patience.
Thank you, sir, for the excellent talk. So that the fixed-drug combination will improve the complaints in the patient and reduce the complications, sir. Thank you very much.
Now all the three sessions are open for discussion. Any questions from the audience?
Sir, I totally endorse your statement. I have been using this 3-drug regimen for a couple of years. My only question is, there is no evidence in ADA or ESD to use SGLT2 in pre-diabetics or early diabetics.
Sir, at the moment, the treatment in pre-diabetes, the cornerstone is still lifestyle modification, and metformin is the only drug used that has been approved by the FDA. As far as off-label drugs are concerned, two drugs are being considered. One is pioglitazone, the other are SGLT2 inhibitor. And I've done a lot of work on this, and there are a group of patients of when you do clusters of patients in pre-diabetes also. In diabetes we know, but you can do clustering in pre-diabetes also, and there are the patients who are obese, who are going to have cardiorenal complications, and they are the persons who will benefit more from SGLT2 inhibitors, even in pre-diabetes, whether you are using it off-label. But only thing is, when you are using these two drugs as off-label, please make it a shared decision-making with the patient. you must write that I have talked with the patient, you must convince the patient it is not in the guidelines, but this drug is going to benefit. So if you have a shared decision making, nobody can touch you medically.
I've been using for a couple of years this medicine, pre-diabetes, the HbA1c from 6.4 jumped back to 5.7.
Right, sir? If you use it, tomorrow it will come in the guidelines. As simple as that. Unless we create data, what are guidelines? Guidelines depend on
So why
data.
don't we do, we draft our own guidelines, RSSBA, sir. We are the biggest body in the world.
RSSBI is doing that work. RSSBI guidelines are slightly different from the ADA guidelines. They are not ditto copy of the ADA guidelines. They are slightly different. We are trying to follow the Indian phenotype.
I think, sir, in the RSSDI guidelines,
Sir,
they are
ESPE,
going
why
through
should we
a lot
follow
of
that, sir?
change. Because I am also both are national EC member. So we in the EC already we have started online updating the RSSDI guidelines. I think you are not aware. but
I think there is also another very good
So
study.
just like ADA guidelines, other guidelines for updating month by month. So many things will come in the near future. We don't have enough Indian data. The moment we get enough Indian data.
Sir, we would like to have some questions here, sir.
We are going to incorporate in our Indian guidelines.
Thank you. Thank you. Thank you, sir, for your excellent talk. And I, of course, from senior doctors, it's always nice to hear your inputs. Just to add that SGLT2, as absolutely like you said, sir, of course, there is no guideline and it's not yet recommended in type 2, in pre-diabetes. However, DAPA-CKD trial and many of the SGLT2 trials in renal outcomes have been used in people even without diabetes. So the DAPA-CKD was one of the largest trials with an SGLT with dapagliflozin, even in that included patients even without type 2 diabetes, in which they showed, of course, improved renal outcome. But the icing on the cake, and in the sub-analysis, they found that there was a significant 30% reduction in the incidence of type 2 diabetes in those without type 2 diabetes to start off with. So your statement is absolutely true, and we do have data to back that up, and maybe it's going to come into the guidelines soon.
In many forums, when I raised up the question, they say the same thing. No ADA, no EST, no ASTE. So,
No, you don't have to depend on foreign
because
guidelines.
You are all pundits. I know you are a pundit. He's a great pundit. I know that.
You don't have to depend on foreign guidelines.
Sir, that's what I'm asking.
As he very rightly said, if we have used SGLT2 in patients without diabetes, why they cannot be used in patients with pre-diabetes?
Because all the worst things can happen in pre-diabetics. The cutoff point for 126 is you see retinopathy in 126.
You have hit the nail on the head when I said more than 15% prevalence of pre-diabetes, and we are worried more about that than about diabetes with prevalence.
101, 136.
Sir, I think we are running short of time. There are other speakers are there. So, yes.
Just one comment on that. I came late, I didn't hear the discussion, but many people don't know this. IDF has removed the term pre-diabetes. It is not called pre-diabetes anymore. It is now called early diabetes. It is called early diabetes because of this reason.
So one last final question to Dr. Nandita. Regarding this GLP-1 analog, about the weight control by this drug, does it has any role in sarcopenia?
Sarcopenia, I think I would be a bit wary to use it, sir, because GLP-1 therapy, if you look at or incretin therapy, especially GLP-1, if you look at the mechanism of action itself, it is going to suppress the appetite, it is going to promote satiety, delay gastric emptying, and result in weight loss. And so in people who already have sarcopenia, I would probably be a little wary to use that. And the benefit, of course, now they've been approved in terms of weight loss and now been approved by the FDA as even anti-obesity drugs in higher doses. So I would probably be a little dicey, it would be a little dicey situation to use it in people who are already sarcopenic.
Thank you.
I would like to ask Dr. NK Singh, what are the two contraindications of gliflozin SGLT2 inhibitors in patients with type 2 diabetes?
Contraindications. One, if you want about the pregnancy, could be one contraindication. Pregnant ladies of type 2 diabetics, that is not approved at all, so you cannot use it. And if there is contraindication, also if there is recurrent JTI, recurrent UTI, urosepsis, before starting, you tell yourself, I am not able to catch what you are saying.
One, of course, is, people, when you're taking history of patient of type 2 diabetes, and that what she was saying earlier, that will come in that, those who have had a history of unprovoked decay, they are the persons who should never be started on SGLT2. Number two, severe sarcopenia, they should never be started on SGLT2 inhibitor. Patients with sarcopenia, mild to moderate, you can start, but with caution. But severe sarcopenia, definitely not. And one question to Nandita, what was the non-responders as far as the weight reduction was concerned, and how many people stopped the medicine after 6 months to 1 year? I'm talking about Rybelsus.
So thank you, sir. Thank you for the nice discussion. We have one more session, another 1 more hour. So I welcome all the speakers for the give a round of applause. Thank you. I welcome Dr. Kalaichali madam to present to Dr. Veeramani sir. I welcome Dr. Nandita to give to Dr. Anand sir. I thank everybody for the wonderful discussion and participation. Thank you once again.